Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Evening, everyone. Welcome to tonight's Lung Cancer Living Room. Welcome, everyone in the room, all of those signing in online from near and far away. We're so happy to have you here tonight. As you know, tonight's conversation is going to be, it's pretty exciting. I don't think we've ever done a living room like this before, if you can believe that. But we're going to be talking about some diagnostics, some new and exciting, I'm not working?
For now.
Okay, do I have to start over? Or? No, I'm good. Okay, sorry.
Exciting.
Some exciting things happening in the diagnostic space and why that's relevant to everyone in the room and everyone watching. And then we're going to be talking about multi-modality treatment. And for those who may not know what that means, Drs. Daly and Dr. Riess, who will join us shortly, are going to talk a little bit about that. In particular, what role radiation may or may not play in your therapy. So we're really excited to have this conversation tunite. Nobody wanted to sit in this couch this evening. I don't really know why. It feels kind of weird. That's okay. Unless you guys want to. Am I going to call out Roslyn and Francis?
Is it like church?
I know. Like nobody wants to sit in the front pew.
Yeah.
So we're going to start with the around the room, and then we'll jump into some introductions from our docs. They've both been here before, so I think you're all very familiar with them. But we're gonna have them do their introductions themselves, because I just feel it's more personal for them to tell you who they are, why they do what they do, and why lung cancer matters. So we'll get to that after we do the around the room. I'm going to start with Rick because I'm looking right at you. And don't forget to pick up your mic. And I know Bridget already announced it, but just a little bit of housekeeping. If you have a cell phone that you have not silenced, please do so, just so it doesn't interrupt something brilliant that someone like Rick might be about to say. So with that, I'm going to turn it over to Rick.
Hi, all. My name is Rick. Stage 4 lung cancer, ALK positive, little over 5-year survivor to date. Plan on making that number much bigger. Had CyberKnife last month. That was successful. And all is well. Just pushing on.
Hi, I'm Sally, and I was diagnosed. Well, I've been NED for, it'll be 11 years next month. I was found early. You can't hear me? Okay. I was diagnosed due to early detection at stage 1A. Oh, now it's on. There you go. Anyway, I entered an early lung cancer research test and was discovered that I had some nodules, and took about 5 years for one to grow enough for me to need surgery, 1A, and never needed any further follow-up with it. I am checked yearly because of other nodules, and I'm just very lucky. And I just want to add, if anybody, this is for patients and caregivers, we're having Bingo 2 from the Lungfish Society on March 15th, and it'll be playing bingo and right here in this living room. And it's our second function. We had a wine tasting last year, and it'll be on Sunday, March 15th. And if I did not send you an email about it, please get a hold of me or get a hold of the foundation, and they'll give me your email address. And we hope that a lot of people can come. Miss Bonnie will be here. So that's our main drawer.
Are we playing for money?
Prizes.
Prizes.
They're
Okay,
gonna be
prizes.
prizes.
Gambling's illegal.
Gambling.
Prizes are surprising. This is another member of our committee.
I didn't know about the prizes.
Secrets.
Okay. My name is Tina, and I've been coming here for a while now. I was diagnosed in 2010, and I had radiation and chemotherapy at the get-go, and then I was tested for EGFR, and it was positive, so I went on Tarceva after treatment as more of an insurance or a maintenance thing, and I'm still on Tarceva, so.
And living large.
And living large.
I'm Rick, and she's my caregiver.
I think we need to get you a 50 sunscreen is what we need to get you.
We put on the links, yeah.
Right?
Thanks, Ina. I'm Marie, and I was diagnosed in, I think it was about October 2018. I have the RET mutation, which only about 3% of the lung cancer patients have, and also thyroid cancer patients have. And I progressed in 9 months, even though I'm really healthy. That was a bit of a shock, and had a bone met in my femur. So I guess I wish that everybody gets scans often as soon as they take you off treatment, because it would be so much easier to have radiation on something that isn't problematic, because once you start getting something in the femur, it just kind of affects a little bit of your daily life, and it's easy to get another one. So I think that's the call out I would give to people is, if your oncologist doesn't recommend, a general oncologist doesn't recommend it, once they start taking you off of treatments, say you want a scan. And right now because I progressed, I am on a new study for LOXO 292, and it's going great. So I see Dr. McCoach at UCSF Mission Bay. She's a thoracic oncologist, and they actually have some openings in the study. It was presented at ASCO, I think 2018, and it's doing phenomenal, but you have to have the RET mutation. There's not many, but if you do, there's, for patients that are treatment naive, they have actually openings in the clinical trial. So I'm on the one that's more advanced, so they've already figured out what all the hiccups are. And I go in for scans and tests, and I'm really well monitored. So that's going well, and I'm getting a scan on the 24th.
Do you have an NTRK mutation or MET?
Right.
RET, R-E-T.
Okay.
Yeah. And
That's great.
I have a 6 millimeter lesion in the femur. So I'm going to try and see, is it from not being on treatment for 4 or 5 months, or is it that the LOXO maybe isn't getting down in that area? But the LOXO also works on preventing brain mets also. So it'll be interesting to see how it works. Thanks.
Thank you. You're our first RET, I think, in the room. Mm-hmm. Yeah. Yeah. Rat.
Hi, everyone. I'm Ina, and I've been also coming for, I guess, about 3.5, almost 4 years. I'm 5 years post-accidental finding of early stage on my left side, and I had a lobectomy, which kind of took care of that. And then last April, I had another on my right side, but obviously I was under surveillance, so it was also early detection. So that's kind of my mantra to everyone I know who has any kind of symptom, to just keep on pressing to get a proper diagnosis. I mean, really get a scan, demand a scan. And the treatment on the right side has been, I had stereotactic radiation, and it was great. It is great, except I have an errant marker. One of the markers has, I guess, gotten loose. I don't know. I know a lot of you know this that know me, but anyway, so there isn't very much you can do about it because it's there and it kind of causes a lot of pain. Right now it's like a lot of coughing, kind of like to try to get something out of my lung that is not supposed to be there. But other than that, which isn't really horrible by any means, I'm fine, and I'm going to see the interventional pulmonologist this week and have a CAT scan, and then see everybody next week. So I think it'll be fine. The solution isn't a very good one because you have to go into your lung to get the marker, and I think I'd rather live with it, but we'll see how it goes. Anyway.
Okay.
That's it.
Thanks, Anna.
Hi, my name is Larry. I was diagnosed in 2013 with stage 4 non-small cell adenocarcinoma. I have an EGFR mutation. My first treatment was chemo. I did that for a year, then did chemo holiday, and was lucky enough to go a whole year without progressing. When I did progress, I started on Tarceva. It lasted for 20 months, and I've now been on Tagrisso for almost 3.5 years. Good scans. Along the way, I had CyberKnife on 3 brain mets. One of those continued to grow, and it was surgically removed in 2016, and since then, the brain's been stable as well. And happy to be here in the living room, as always. And tonight, my wife, Thayer's with me for the first time.
Hi, I'm Thayer, and I am Larry's wife, obviously. But anyway, I would say he's done better on this journey than I have. He takes everything as a bump in the road and moves on. It takes me a little longer to catch up with that. But I'm beginning to realize that caregivers have to take care of themselves. And so that's an important lesson that I've learned. But I, thank the living room and everybody here for all the support all the time. So I appreciate it. Thank you.
Thanks.
Thank you.
Hi, I'm Tim, and I was diagnosed with stage 3B adenocarcinoma non-small cell last year, and did 6 weeks of radiation with chemotherapy, and that knocked the tumor down 70%, and then had over 50% PD-L1 expression, so went to Imfinzi, or Durvalumab, and I had a PET scan a month or so ago, and the doctor says that the tumor that was around my heart is basically gone. It's dead. And I have CT coming up on Friday, and just by the way I feel, I'm starting to get my voice back, which, if some of you remember, was very scratchy. So just the way I feel and how I can breathe and everything, I'm assuming that it's going to be another good scan. I'm here because I know from listening to my friend Dawn that we recently lost, that that we need to stay connected, that alone this is a difficult thing to manage, but together, sharing information, staying connected, we can make a difference together. So thank you all for being here. I appreciate it.
Hi, everyone. I'm Carol, and I'm Don Stranathan's sister, and I think most people that know him know that he passed away on February 1st after living with stage 4 non-small cell lung cancer for 10 years and 8 months. So after his 10-year survivor party this summer, when I met some of the people from the Go-To Foundation and some other amazing survivors and advocates, I was really moved to become a lung cancer advocate and radon educator. So my background is in public health nursing, so I've done a lot with smoking cessation, but of course we know that smoking's not the only cause of lung cancer, and I feel like radon just isn't talked about enough. So I read Bonnie's book, which is amazing, the 360. And I mean, really, I think we should call you Dr. Bonnie, because it was amazing. And so
She did it.
Oh, well,
Yeah.
Dr. Danielle. Okay. So
Just my picture.
it was, it was amazing. And so I put together a PowerPoint on lung cancer and radon. And so I'm happy to report that several people got radon tests after hearing it. And one person got the low-dose CT scan because they met the criteria for former smokers. So the other thing that happened after Don's party this summer is I had met Susan Smedley, and I knew that she kind of coordinated the races and stuff, so I connected with her. And Eau Claire, Wisconsin, where I'm from, has a marathon. So the Eau Claire Marathon picked the Go-To Foundation as one of their charity partners. So we will volunteer, and then they'll pay us money and give it to the Go-To Foundation. And then we have a team of 4 people that are doing individual fundraising, one of who is ALK positive. He was diagnosed 2 years ago. So, and then Susan made our fundraising page into a memorial for Don. So anyways, I know Don loved everybody here, and it was really important to him, and he always said, you know, the reason he was here so long, not only because of the doctors and the nurses, but Bonnie and all of you. So thank you very much.
I don't know where Bridget is, but we need, oh, there you go. We can start anywhere. There you go.
Do we lose?
Oh, my name's Don. This is my second time here. I also have stage 4 lung cancer, EGFR, and at the same time also asthma. And that's why my voice is really hoarse because of the asthma medication. I do take Tagrisso, and it has, I actually had a scan already, and it did shrink the tumor by 30%, but it's also shrunk my energy by about 40%. So.
And I'm Elaine Horsley, his better half. And this is my first time here, and I'm glad to be here.
My name is Ken Chen, and my mom's stage 4 EGFR, and for the last 3 years, and she L858R, and she's really lucky. We came here, and then we got referred up to UC Davis and been seeing Dr. Riess for the last 3 years. So she's doing really well. Thanks.
I'm Maureen Smith, and my nephew, who's 48, has been diagnosed with cancer, lung cancer. 3A, ALK mutation. So I'm happy to be here, too.
I'm the mother of the patient and obviously very distressed about it. He had surgery and 4 rounds of chemo at Stanford, and he looks great. It's just that now they've found at the 34 lymphs that they took, they found 19 more cancer. It's kind of a stunning setback, and that's why I'm here hoping for some sort of guidance. Thank you for having me.
Thanks for coming.
Okay, thank you.
My name's Roslyn Pruitt, and I was the caregiver for my husband, Francis. So I'll let him talk now.
Francis Pruitt, 12 years. Stage 1B, I had a right upper lobectomy on Christmas Eve that year, 2007. And then 4 cycles of chemotherapy in the spring of 2008. Always very good to be here, meet with long ago friends and new people. So thank you.
She's going to pass it to me again. My name is Nadine Parker, and this is my wife, Amita Jain. And for us, lung cancer was something we discovered in August 2018. Amita's mom was diagnosed with lung cancer. They were not able to find any mutations, so she's on, I think, these 2 drug therapy. And so she's doing pretty well, but just gets very tired. 6 months after that, January of 19, was when Amita was also diagnosed with lung cancer. In her case, the symptoms were more neurological. That's how we discovered that she had lung cancer, and it was very surprising because she had no respiratory symptoms. She has ALK. Both of them have stage 4. And she has gone through a couple of medicines, alectinib, on which she was there for a couple of months, but unfortunately didn't do very well, had side effects. Now she's on brigatinib for probably about 10 months or so. And so far, so good. We're keeping our fingers crossed. She has been doing very, very well. So for us, my daughter was the one who discovered the Lung Cancer Society, so we are very glad. And the thing which worries us is, of course, are there any genetic, familial things that we have to worry about? We just discovered on your website that there are a couple of institutes doing some research on that, and we would like to find out more about it. And then I would like to thank Dr. Riess. He's been giving us kind of second opinions pro bono. So thank you.
Hi, my name is Wayne.
I'm Rebecca.
Rebecca is a stage 4 lung cancer survivor. She's got KRAS G12D, no PD-L1 expression, non-smoker. She was diagnosed in November 2017. Her treatment started with chemoradiation, followed by durvalumab consolidation. She had some progression, developed some brain mets, got that taken care of with SBRT, and then
We love that one.
and then she lasted about a year with carbolimta and Avastin, and there was some slow progression, and we found our way to a clinical trial at UC Davis where Dr. Riess was the principal investigator. It was a trial with trametinib and pembro. She lasted about a month, unfortunately, due to some severe side effects. She got rashes and she got sores in her mouth and she couldn't swallow. She got hospitalized for about a week for that. And so it was.
It wasn't your typical outcome for most people.
We're hopeful that we could have stayed longer with him. So she's been on gemcitabine since October, and doing great. Her scans, her recent scan were stable to mildly improving, and so we're just going to try to ride this one out for a while.
As long as possible. We love this one. This one's so good. Easy, I can do things, I feel great. So.
How was Hawaii?
Oh my God, Hawaii was wonderful. Isn't Hawaii wonderful? And then we came back and
froze.
But we did a nice little trip this week, so.
Yeah.
Good.
Nonstop. It's nonstop.
Hi, I'm Catalina. I'm a caregiver for my mom, Ivica. She was diagnosed in November 2018, stage 4 non-small cell lung cancer, never smoker. Her PD-L1 is 5%, so pretty low. She's tested multiple times for genetic mutations with Foundation 1 and Guardant and has come up negative for the known ones. So she did 9 rounds of the standard first line, which was Carbo, Alimta, and Keytruda. And then when she had progression, she started on a clinical trial with Nectar, which was Opdivo and a different immunotherapy. She felt really good on that, but she had progression. So for about 2 months, she didn't have anything while she was exploring options. And she just started the docetaxel chemo and the ramucirumab. Finally got that one last week. So they're doing split dosage. So she goes again tomorrow. So we'll see how it goes in about 6 weeks.
Thanks, Kat.
Good evening. My name is Jane Canalao, Rojo Canalao, and this is my second time to attend the GoTo Foundation. I was here last month, and my medical integrative oncologist, Dr. Donald Abrams, was the one who told me to come and join the group because I saw him January 13, and I told him that, look, Dr. Abrams, my oncologist, well, first of all, my history, I was diagnosed with stage 3A lung cancer in January of 2017. And I had a lobectomy at Stanford also, February 17, 2017, where my thoracic oncology surgeon removed my whole right lung lobe, which had about this big of a cancer, and also 11 of my lymph nodes, because one of my lymph nodes had already cancer. They started me on 4 rounds, supposedly 4 rounds of chemotherapy with cisplatin and Alimta. Unfortunately, on my 3rd chemo on May 12, 2017, 2 days later, I ended up in the ER because my BP was about 190/90, and I called the doctor and they said, come to the ER, and they found out that I had heart failure because of fluid overload that was caused by my infusion chemo. So they stopped me on that, and in July or August of 2017, they started me on Tarceva, and I was supposed to be on Tarceva for 2 years. As you know, everybody who's been on Tarceva, you get severe rashes, and mine was really severe, that after 4 or 5 months, Dr. Neil, my oncologist at Stanford, wanted to stop the Tarceva. And I said, no, this is my only medication. This is my only treatment. Don't stop it. I don't care about the pain and the itch and the whatever it is that's causing me my scalp. I had to shave my head because I did not lose my hair from chemo, but I had a lot of, lesions in my scalp, and it wouldn't go away, so I had to shave it. So I was on Tarceva, and then also after the May diagnosis of heart failure, 6 months later, I had kidney failure stage 3 as well because of the infused chemo that I had. I had 3 sessions of it in 2017. So then in March of 2018, I had an anaphylactic allergic reaction to Tarceva. And Dr. Neil told me, we have to stop this, Jane, or you're gonna die. So you can die from this medication. So I stopped it, and I was cancer-free until in August of 2018, my cancer came back. And they found 4 lesions, 1 in my right lung middle lobe and 3 in my right lung lower lobe. And they were still small, and they were growing at a rate of like every 3 months I would have a scan, and I would see my oncologist. And so it kept growing. And so in September of 2018, I realized that my options for treatment is very limited because of all the side effects I had. Heart failure, kidney failure, and then the rashes and all that. And so I decided to ask the librarian, the cancer center at Stanford, to help me research an integrative medical oncologist who will work with my oncologist to see if I could get some alternative treatment, in case I don't get any treatment. And so I started seeing Dr. Abrams at the Osher Cancer Center at UCSF in March of 2018. Then I saw him again in July 2018. In June 2018, chest CT scan showed that one of the nodules started becoming aggressive. And so Dr. Neal said, well, it's at the size. It was like 10 by 7 millimeter. It was at a size he said he could start treating me, and he found this pill called gefitinib that doesn't cause heart failure. So I started on gefitinib on July 6th after they put me through a drug allergy challenge test, which I passed. I did not have immediate allergic reaction to gefitinib, and they started me that. After 6 weeks, he ordered a chest CT scan, and my cancer cells were decreasing in size and depth. So I was really happy until I ended up at the ER. I could not breathe. I had shortness of breath, and I went to the ER at Stanford, and they thought I had a blood clot in my lungs, which is, they said, is common for people who have lung surgery. I didn't have any blood clot, and when they did the ultrasound on my legs, I had no clot either. And then they did a chest CT scan with contrast, and they pre-medicated me because I am allergic to iodine contrast. And they found out they couldn't see my lungs. It was a lot of opacity there. And they said that my gefitinib had caused my lungs to have pneumonitis. So it had severe lung inflammation. And that's what's causing my shortness of breath. Nothing about my heart, thank God, and it was not a blood clot, thank God. And so they put me on prednisone. I was in the hospital for 9 days, and I was on prednisone until December 22. Dr. Neal ordered another chest CT scan, and in December 20, he said, Jane, your cancer is growing again. So it's back to whatever it was, from 7 millimeter to 4 to 10 again, and 7 millimeter. One of them, and the others are also growing, and he said there's little ones. My pneumonitis is a little bit better, although there's still some, and I am on a as-needed oxygen, and I have this pulse oximeter I carry with me around all the time. And Dr. Neal sat down with me, and he said that I can't give you any more treatment because everything else there will cause heart failure. And if I give you treatment, you'll die in 6 months to a year. And so with your cancer being small, it will take years before you die. And I said, oh, how many years do I have? And he said, I don't know right now, So that's when I saw Dr. Donald Abrams. He was the speaker the following week here, and he said, go to my lecture. I will go to this foundation and go. And I really love the community, and I know that I can get some help or maybe some hope and knowledge in here. So hopefully that maybe 2 years, 3 years, 5 years, or maybe more, I still have that, and I'm not giving up.
Good.
Thanks, Jane.
Okay. Thank you for that. My name's Eric. I don't have lung cancer. I'm a patient advocate now. I'm becoming a research advocate, advocating for more research for lung cancer, which really needs it. And so that's my story.
Hi. About 3 years ago, I went to the Go-To Foundation Gala, and that's where I sat next to Don, and I say I must miss him, and he was a great guy, and he did a lot for everybody. I'm sure we all miss him, but may he rest in peace, and thanks for coming and sharing your story. I have a family history of heart disease, and so they found a ground glass opacity, a nodule on my lung about 5-6 years ago, and we've been watching it, and it's doubled in size now. It's in a very difficult position, and that's one thing that all the doctors agree on, is that I shouldn't have a biopsy. So I'm asking, when will liquid biopsies be available. So hopefully I can do that. But in the meantime, I'm worried if I've left it too long and I should have taken it out. It doesn't have a hard component. It's just ground glass, thank goodness. So I've just been watching it, and it's doubling. So that's my story.
And you travel to a lot of meetings too, don't you?
Hi, I'm Karen. I am a 12-year survivor. I was stage 1B. I was an accidental finding. I had a non-small cell adenocarcinoma. I have the wonderful fortune to be in the class with Bonnie of having Fred Marcus as my oncologist, who was amazing. After 2 hours of discussion with him, I ended up opting for treatment, going through 4 cycles of chemo, just sort of as an insurance policy after I'd already had my upper left lobe removed. And so I'm just here now more as an advocate for the foundation because it's just so amazing, and everyone in this room is just so amazing. The stories, the inspiration, the courage, the spirit. And I just want to go out and tell the world about everything here. So I wish you all well. Thank you.
Thanks, Karen.
Good evening, everybody. My name is Ranlong Zhou. I was diagnosed back in 2014 in November. It's a stage 3B squamous cell. And I went through 3 rounds of traditional chemo, and followed by the surgical procedure. So I had my whole left lung removed. Ever since then, I have been doing the CT scans every 6 months for 2 years. And this April would be my 5th year going through the CT scan. So I have my finger crossed. Always looking forward to this living room every month. Great to see everybody here. Thank you, Goethe Foundation.
Hi, my name is Ron Fong, and I'm here as a lung cancer advocate and a delivery man for Coffee Crunch Cake. So for those who are physically here, you get to enjoy some cake tonight and enjoy it, because it's Chinese New Year's and it's my birthday month. So there you go.
There you go.
I saw it in the kitchen.
My wife had lung cancer and was discovered by accident. And so I would think that today, that because of our broad panel of genomic testing panels, no one should be discovered by accident. Even though you may not fit a profile, there shouldn't be an accident. My neighbor was 30 years old. He was discovered by accident. And even after he was discovered, they didn't do the broad genomic testing. So please, please get tested and do a broad panel test to find out what happens. As it turns out, he wasn't EGFR because they made an assumption that he was Asian, that he had EGFR. And they said, oh, well, you don't have that, then you must be ALK because you're a non-smoker and you're male and you're young. Well, he wasn't ALK either. It turns out he was RET. And there is a RET group based out of Florida online that you should hook up with to learn about RET. And so he's on the LOXO 292 trial as well. And approximately 1 week ago, passed away. It was unfortunate. It's because the doctors and where he were doing their best, but they weren't doing it good enough. And so we need to continue to advocate for our friends, for our neighbors, for our families that get tested and get knowledgeable that lung cancer can strike anybody, and we need to do our best to keep survival going as long as we can. The great news is that not only do we have Coffee Crunch Cake tonight, but that the statistic of 433 a day who are dying from lung cancer is down to 391 now. That's a 10% drop. That's phenomenal. And it's because of participation in trials, it's participation of new findings in testing. And so thank you, Dr. Riess, Dr. Daly, for just participating and getting people in trials and finding new treatment.
Thanks, Rod.
And I wear this hat because I was told that they recognized me because I was on TV wearing this hat. It says "Beat Lung Cancer" on the back of it, and it says "Be a Dragon Warrior."
There you go.
I'm Pat Pritchard, and 15 is my number for today. 15 years ago, I was diagnosed with cancer of the appendix and went through chemo and a lot of surgeries. Then 15 months ago, the lung cancer was discovered accidentally. I was having a lot of trouble breathing, and it was chronic allergies, chronic bronchitis, a lot of breathing things. So they finally did some x-rays and went, whoops, now we got to do more testing. And they discovered the lung cancer I have, non-small cell adenocarcinoma, 2 different kinds, 1 in each lung. So I continue to do weird things. I will miss you next week, or next month. I do get tested and get the results next week, but I've already scheduled a trip to Mexico to the spa.
There you go. That's awesome.
To celebrate the good news that I'm going to get.
Got it, girl.
Hi, my name is Evangeline, and I was diagnosed by accident too on March 2017. I have non-small cell lung cancer, adenocarcinoma. It was found by accident when I was hired at Lucille Packard Children's Hospital, and before I start working, I have to go through the routine check, the X-ray. So they found out I have a mass on my upper left lobe of my lungs. So my primary care physician just ordered series of tests, and that's when it was found out that I have the cancer. I had cyberknife radiation in May of 2017 and immediately started Tarceva. And at first it was, anyway, after 20 months, I have to go through another biopsy, and I'm now on Tagrisso almost a year in April. I will be 3 years in March after the diagnosis. And so I'm on Tagrisso now, and I had my last MRI of my head because I had it metastasized in my brain and left lobe of my skull, left bone of the skull, and the MRI result was it's sleeping, and hopefully it will stay dormant. And I had a CAT scan too last month, and it shrunk from 3.8 centimeters. It's now 2.5, which is good news. And according to my oncologist, we hope that it will continue shrinking and stay dormant. And that's the good news, that God has the grace, the blessings and grace from God that I received. Thank you. And this is my friend Candy. She's my moral support in church, and she tries to come with me to be my moral support since I have no family around.
Hi, I'm Candy Hernandez. I'm Evangeline's friend. I also have cancer, but not in the lungs. It's in a different part of my body. So she supports me and I support her, and we compare notes. So we are best friends now. We go to church together, and I'm just overwhelmed to hear the stories of everyone here. And I support all of you because we all have cancer.
Hi, I'm Virginia, and I was diagnosed with lung cancer July of 2018, went through a clinical trial, had my left lung removed, and used a targeted therapy for 2 months. I had my year scan, and it's been clean, and I'm so excited. And I'm excited to share that news, and I'm more excited about just being here and being with you guys. So thank you very much, and thank you for this foundation.
Hi, I'm Ayala, and I'm happy to be here. Actually, I'm from a biotech company. I'm a clinical science liaison. I had the permission to attend it to learn more about the foundation and about the research. Thank you.
Welcome.
I'm Joann, and I was diagnosed in September 2016 with non-small cell adenocarcinoma, EGFR positive. I was put immediately on Tarceva. Oh, just backing up, I was misdiagnosed for a year before they finally did a chest x-ray, and one thing led to another through all of the CTs and PETs and MRIs and all that to diagnose the stage 4. It had metastasized to the left adrenal gland and bone. The Tarceva shrunk everything pretty immediately. In fact, it's gone from the bone, still a small lesion on the left adrenal gland, and still a tumor, although shrunk to half in size, in the right middle lobe. I was on Tarceva for 2 years, 23 months, I think it was exactly. And at that point, I had started being in a trial at Natera for testing for progression through circulating tumor DNA. And a test showed that it was going up, and a subsequent CT scan showed that maybe something was going on in the adrenal gland. So then a PET scan showed that something was going on in the adrenal gland, and it was small and isolated. So I had, no, wait a minute. No, that's now. Okay, back up. It was going up, and no, okay. And a garden test showed that what it was T790 M, right. So then I was changed to Tagrisso. Okay, Tagrisso for over a year. And that's when I was in the trial, and the circulating tumor DNA showed that something was going on, and it turned out to be something in the adrenal gland, isolated. I had stereotactic radiation, and I had a blood draw right before it for a baseline, and then I have a blood draw tomorrow at the 3 weeks point to see what's going, if it's stopped. What we don't know, the doctors at Natera, is how long the residual from the radiation will still be in my bloodstream. And so I'm kind of a test case here to see how soon this particular blood test would really tell the story. And that's my story. Thanks, Joann. Are we done? Where's it going? You guys good? Yeah.
It's me. I'm late, so I'm lost.
That's okay.
My name is Jennifer. I was diagnosed in August of 2018. We were away for a weekend, and I had a seizure, and found out in the OR or the ER, I should say, that I had stage 4 with 3 mets to the brain, had cancer in my adrenal gland, my lung, and my C3 spine. So no symptoms whatsoever, had no idea I was sick. So that was quite a shock. But since then, have really responded very well to treatment. I started out with be it cisplatin, Alimta, and Keytruda, and did 3 cycles of that, and then have been on Alimta and Keytruda since then for just over a year now, and been stable. No movement, no growth, no new mets or anything. I just had a PET last week. Everything looks great. I did take a little chemo holiday over the holidays, and kind of by choice, just because I wanted to give myself a chance to kind of get the toxicity out of my system at risk, I know, but it was a good choice, and I didn't progress, and it wasn't a detrimental decision that I made for myself, but that's a little nerve-wracking. But together, the doctor and I decided that would be safe. I'm due next week for a MRI and go from there. But right now, all my mets in my brain are gone. I just have some scar tissue that we're keeping an eye on. So, all in all, doing well. Thank you.
Thanks, Jennifer.
How much genomic testing did you have?
I had a basic panel. I am EGFR exon 20 with PDL. I think it's medium expression 31 to 40. Okay. Yeah, and we did discuss that at my most recent appointment and said that if I were to progress, we would definitely take another. No, not trial drug, but another biopsy and do further testing just to get a bigger picture. But I think I was tested for the primary, maybe there's a handful of 10 or so that they test for that were more predominant.
Great. There's a foundation out there that just focuses on exon 20. I'll introduce you to them.
Oh, a foundation.
At the end of the meeting.
Okay. Because I know when I saw my doctor just this last week, he talked about a trial. I want to say, is it Posey? Posey? I forget the name of it. It's in here. Anyway, he talked about a trial that I could go to, but I would love to get that information. Thank you.
And I'm sure these folks have something to say about that too. Exon 20 is kind of a different animal in the EGFR family.
Thank you.
Thanks, Jennifer. Thank you all so much for sharing your stories. As I was going around listening tonight, I couldn't help but kind of do some flashbacks to when this meeting first started, 9-10 years ago, to where it is now. And it's why we do what we do. And I can't thank you all enough for continuing to come every month and sit in this room with all of these cameras and share your stories with the world, really. It's so much appreciated, not only by us here at the foundation, but by all the people out there in TV land who get to come back and watch and learn from you. So thank you.
And we never do this. We never really talk about this, but I can't remember when we started, but it was a long time ago. And it all came about because I was asked to go speak at another hospital at their support group. And I said, of course. So I went, and I walk in this room, and it was a gray room with gray folding tables, gray folding chairs, no windows, and gray people. And I thought, I'm not really seeing any hope in here. I'm really not seeing anything like that in here. So I came back and told our team, I said, you're going to kill me, but we're going to start a support group. And they went, oh my God, geez.
And by we, she meant me.
Right.
That's
Aren't we
really
doing?
meant.
Don't we have enough to do? And I said, no. We're going to start our own support group, but it's going to be different. And that's where the name, the living room, came from. So it's kind of a little double entendre, right? Because there was nobody living in that other room that we were in. There was just no hope, and there was no education, and there was a social worker, beautiful person, but not really helping much. So that's where all this came from. And over the years, we've seen some miracles, some miraculous things. We've met some amazing people, and we are, you all bring your families and you gather together, but we are really all family, right? We're all family. And it's pretty amazing what we've been able to see over the last 10 years, and the progress over the last 10 years. Because I think when we started, it was EGFR. But it's like, wait a minute, there's more. There was no.
I think
MET
when we
then.
started, it was, what do you mean they test for what?
Right. Testing what?
Testing for what?
What?
Yeah.
So whenever you get down a little bit and you're thinking, things aren't moving fast enough, there have been more new drugs approved in the last 5 years than the last 5 decades. So, progress, which they'll tell you more
And
about
on that note, I know that Doctors Daly and Riess don't need any introductions in this room, but around the country they may. So I'm going to ask that they both take turns, just introduce yourselves, say who you are and what you do, and then we'll jump into tonight's topic. So Jonathan, you want to start?
Sure. Hi, everybody. It's great to be here. Thank you again for for inviting me. It's always nice to come down here.
Well, you're family
and
too.
talk. Well, thank you.
You both are.
I'm a medical oncologist at UC Davis who primarily takes care of lung cancer patients, and I also focus on doing research and trying to come up with new effective targeted therapy and immunotherapy combinations to try to overcome resistance to existing treatments.
Right. And I'm Megan Daly. Thank everybody again so much for the invitation to come. Jonathan and I are so excited to do this together. I think it's been 5 or 6 years since I've been down here, so it's really special to be back. I'm a radiation oncologist at UC Davis. I primarily focus on lung cancer, and my research focuses on a few areas. I'm very interested in ways of combining radiation with some of the really amazing new drugs that are coming out to try and synergize and make the radiation more effective and the drugs more effective. And I'm also very interested in ways of making radiation have fewer side effects and be less toxic when we're using it in the chest.
Which is awesome.
Thank you. And they didn't really say nearly enough about themselves because they're really doing amazing work, absolutely amazing work. And we're starting to see chronically managed lung cancer. We had a patient, a stage 4 patient, just last week that had surgery that was stage 4, and they finally lopped out a lobe, and after all the treatment she's been on over a long period of time, you know, at the moment she's cancer-free. Yeah, so all good news. But they're amazing, rock stars.
Yeah, they really are. Before I jump in, I was remiss in asking if anyone online needed to shout out or say anything before we jump in. Awesome. Thanks, Amy. For those of you in the room, I think you know this, maybe you don't. Amy Moore, who you guys all know Amy. She's our Director of Science and Research here at GO2. And then Michelle Zay over there in the corner. She loves it when I call her out. Camera's her favorite place to be. Michelle oversees the living room. So not only does she work with all these amazing doctors and researchers and speakers and others who come in here to San Carlos, but the 6 we do regionally, and then the 2 we do outside of the U.S. She pulls all that together for me, man. I don't know how I would keep telling her she can't quit. If she did, I'd be lost. So thank you to both of you for moderating online tonight. So with that, we're going to jump in. We're going to talk about diagnostics and multimodality treatment. The diagnostic part, we won't jump too much into what's available now insofar as we're going to talk about sort of in the follow-up space, right? So you guys all know CTs and PETs. A bunch of people talked about them. We're going to talk a little bit about what's happening with the Explorer, and then Megan and I were talking about this right before about new tracers under development. So I don't know who wants to take the lead on this. If you want to talk about maybe Explorer first, what it is and why it's important, and then go into the tracer. Sure? Okay.
Sure, that sounds great. Dr. Daly, Megan can go into more detail, but as our lung cancer radiation oncology expert, but the Explorer PET is essentially a total body PET developed mainly at UC Davis that is more sensitive than most standard PETs in terms of detecting metabolic activity and potential cancer lesions. And so, we've deployed that now and are now using that both in patients and in clinical trials. And it also could be potentially faster with lower doses of radiation depending on the situation, so they could hopefully perform scans more quickly. And so we've been looking at these both in patients as part of standard of care and also in clinical trials with some of these novel radio tracers that Megan can talk more about.
And I think we had a question before.
Oh yeah.
Rick, don't forget your mic. Oh, and I want to remind people in the room and online, please, that this is Q&A throughout. So if you have a question, just raise up your hand, and if I don't see you, wave it vigorously, and I'll find you.
So, quick question. That PET, will it work in the brain, or is it like a typical PET that will not, because the metabolic rate is high anyway?
That's a great question. So I'm going to defer that to Megan to answer.
So the short answer is not really. So the problem isn't the PET scanner. The problem is the tracer you're using, because the brain uses a huge amount of glucose. So when you're using FDG, which is fluorodeoxyglucose, it's taken up not only by cancer, but it's taken up by your brain because your brain is using lots of glucose. And in a second, I'm going to use that as a segue into talking about some of the other stuff we have going on. But I think just to add on a couple of things to what Jonathan was saying about the Explorer, a few of the things that are really cool about the Explorer, and I think will eventually really make it a bit of a game changer. Because of the sensitivity, it is vastly lower radiation exposure, which does eventually open up the possibility of being able to safely do PETs much more frequently. It also allows us to, I'm sure many of you have, if not most of you have had a PET scan done. Typically, you get an injection of a tracer, you sit in a dark room for an hour, and then you get scanned. With the Explorer, because it's so sensitive, you actually can scan the patient the next day, potentially. And that, because it's so sensitive, there's still a little bit of radiation being emitted. And that actually, in some cases, may let us differentiate between things, cancer and other things that tend to give us false positives on PET scans. So it opens up a lot of interesting possibilities. Coming back to the question about the brain, so FDG doesn't work. There are some other tracers that are very interesting. Tracer meaning thing you get injected before the PET scan. There's a couple that I'm familiar with that are in tests at UC Davis. I know centers around the country, Stanford, UCSF, they're also looking at lots of PET tracers. For example, one of my colleagues, Julie Sutcliffe, in our nuclear medicine department, has developed a tracer to something called beta-6 integrin. And I've seen some of the images, and it actually works very nicely on brain mets because the brain doesn't take up this tracer at all. So you see perfect images of brain mets in some patients. So it's still completely experimental. It's not ready for prime time yet, but eventually some of these tracers may help. It would be really amazing if instead of having to do a brain MRI and a PET scan, you could just do one tracer, especially one where you don't have to fast, and you get an image of the whole body plus of the brain. There's other tracers that might specifically be really great for following a particular drug. So there's one that we're just starting to look at UC Davis, also at UCSF, that specifically looks to response to immunotherapy. So it looks at T cells, and hopefully we're hoping it'll give us an idea of whether immunotherapy is working very early. So if it isn't, we can switch quickly and we don't have to wait for somebody to progress.
So how far out do you think that is for practical use?
So both of the tracers I mentioned are in clinical trials right now. To be used broadly, they'd need to have FDA approval, so that realistically probably at least a few years.
Can anyone join the trial?
Absolutely.
Fairly quickly.
We have slots on both.
I would be interested in that because the only activity that I have or only progression I have is in the brain, and they can't get a biopsy of it, and you can't really see what's going on. I mean, it's problematic.
We do have slots on both of those trials I mentioned.
And I would also highlight in terms of clinical trials and some of these novel radio tracers, there's a trial that's sponsored by the National Cancer Institute that we hope to have opened over the next month or so, and that's looking at combining two drugs that target metabolic pathways in squamous lung cancer, as well as KRAS lung cancer with specific co-mutations where we think they're susceptible to certain inhibitors of different metabolic pathways, specifically glycolysis and glutaminolysis. And those are being combined, and we're actually looking at a novel radio tracer called doing glutamine PETs to look at this alternative metabolic pathway that may mediate resistance to one drug targeting glycolysis. So by combining them both, we hope to have synergistic activity and actually image that activity in patients on a clinical trial where there's really promising both clinical and early data showing that combining these two drugs to target metabolic pathways in certain mutations in squamous and KRAS lung cancer could have preferential activity. And it was actually partly developed by Go2 Lung Cancer Foundation Research, and it's a trial that's going to be open at UC Davis as well as Memorial Sloan Kettering that was developed with David Shackelford, who was funded by the Go2 Foundation, as well as myself. And Paul Pack and Mark Dunphy at Memorial Sloan Kettering, who've really done a lot of work both with the glutamine PET and looking at this combination. So it was really exciting. And actually, one of the ways I got connected through David Shackelford at UCLA was through a patient who was very involved with the Go2 Lung Cancer Foundation. So that's actually research that in a sense has been springboarded by patients and by the Go2 Lung Cancer Foundation.
And
so
we love to
we're
see
really excited
the younger,
about that.
innovative, more robust thinking people working together. And they come up with some amazing things.
And at UC Davis, it'll be done on the Explorer.
Yeah,
So, so that'll be really
That's great.
exciting.
Great.
So that'll hopefully be open in the next month or two.
But I think, and one of the things I just want to touch on to Jonathan's point, and then we'll keep moving, is some of that seed money or seed funding, if you will. That is all. I mean, that kind of stuff happens because of you guys and others and your support, that we were able to fund this type of research that then, to Jonathan's point, springboards into this other bigger, sort of more exciting stuff. And
right. And a much bigger grant, that allows even more research and to get to the end of the line.
Yeah. So this
and actually bring something to the table.
Yeah. So it's a big thank you to all of you,
right?
Because we couldn't do it without your support.
That's why we make you go to all these 5Ks and all of this stuff.
We don't make them.
That's where the money goes.
We don't make anybody, right? We don't make them. We
sort
don't
of do.
drug them and bring them out there. Does anybody have any questions, or do you guys want to have? Do you want to keep going about? Yeah, just grab a. There's a mic over there somewhere. Thanks.
Yeah, big voice. Thank you. Now, I was just curious. My son has, I better say it, edema cell ALK mutation, stage 3A, and he's had the surgery. And actually, my daughter's texted me here. Is there? He didn't know. He was in a trial, maybe with Keytruda. We'll never know. Would a blind trial? Is there anything new out there for ALK mutation? What he has?
So that's a great question. There's been a lot of research in ALK-positive lung cancer, and so we've got some great initial drugs that are approved. Some of them we've heard the names. Today there's alectinib and brigatinib. Alectinib has was compared to an earlier generation, crizotinib, which was the first generation ALK inhibitor, and showed almost 3 years that go by on average, before the cancer starts progressing, with high response rates and high amounts of tumor shrinkage. There's other ALK inhibitors like lorlatinib that were recently approved once drugs such as alectinib stop working. And there's other ALK-specific inhibitors that are in clinical trials that look to be particularly promising. Oftentimes, us as lung cancer doctors, when one of those drugs stops working, we try to find out why that happened in terms of what are the mutations that cause the cancer to outwit these drugs, and then try to match it to the best treatment, because some work better against some mutations and some pathways of resistance in others. So that's the main kind of broad overview of how we think about treating ALK-positive lung cancer. But there are a lot of exciting ALK inhibitors that are out there and that are being developed.
Dr. Riess, can I just piggyback on that? You may have seen, we just announced a collaborative research grant with Dr. Christine Lovely at Vanderbilt and Dr. Trevor Bavona here at UCSF, where they're looking at novel drug combinations that can try to delay or prevent resistance to ALK drugs altogether. As Dr. Bavona says, we want to, rather than interrogating the black box after the plane crashes, we want to keep the plane from going down in the first place. That's kind of the metaphor that we're working with. And then through the Daly Lung Cancer Medical Institute, we also have a study called Spacewalk that's looking at mechanisms of ALK resistance. So this is a rich area of research. We're invested on multiple fronts in the ALK space, so yeah.
And I would in addition to what Amy was saying, we do have trials both at UC Davis and UCSF, some of which we share and open together, looking based on Trevor Bavona's research, looking at combining a pathway called the MEK inhibitor with an ALK inhibitor, and looking at that in ALK patients that have, especially ones that have mechanisms of resistance that may bypass around ALK. So that's another avenue of research.
I'm new to this, so were any of those things in therapy stage 3 ALK?
Oh, so, these inhibitors have mainly, that's a great question. These inhibitors have mainly been studied in metastatic lung cancer, so not stage 3, but stage 4 lung cancer.
So right now, there's no immunotherapy.
There's no specific immunotherapy drug for ALK lung cancer. In fact, we have some sense that in many lung cancers that aren't related, like ALK, for example, and EGFR, tend to not occur in patients who have a big smoking history. Often occur in patients who've never smoked, and so is essentially not related to smoking. And we get a sense that in those EGFR and ALK, looking at clinical trials, that at least existing PD-1 antibodies don't seem to work as well in those patients that don't have many mutations that are more associated with smoking that could help trigger antigens that stimulate the immune response.
All of the information I've received on ALK and immunotherapy is immunotherapy doesn't work on ALK. It works on many things, but doesn't work on ALK. Would you agree?
Yeah, so,
Or EGFR.
Immunotherapy, these PD-1 drugs in and of themselves, the response rates are extremely, extremely low, if anything. So, we're looking for ways, combinations and how best to combine them and get new treatments in terms of activating immune response in those cancers.
On another note, though, ALK inhibitors like alectinib, crizotinib, brigatinib, lorlatinib, all of those drugs work extremely well on ALK. And life expectancy on ALK is actually quite high. So, if you have to have lung cancer, ALK's not a bad place to be. There is a lot of research in the ALK area, but immunotherapy so far has kind of proven to not work on ALK. You're welcome.
But like they were saying just a minute ago, stopping progression is the key to ALK patients and EGFR patients and all of those patients that immunotherapy isn't really working on now. But what about CAR T cells?
I just want to give a shout out because I know you guys are new to this space and it's incredibly scary. And I know it probably sounds really disappointing about immunotherapy because everybody thinks that immunotherapy is sort of currently and or going to be the do-all to end-all, right? But to Rick's point, there are very good targeted drugs out there specific to ALK-positive patients.
Right.
So I think it's really important that you focus on that. Immunotherapy is not for everybody. It's fairly new to this space, right? So we're still trying to figure out, not we, I'm not doing it, they are, but trying to figure out, right, how immunotherapy, nobody knows how immunotherapy may evolve, but right now, there are really good options, so.
And there's a lot of...
I would just mention specifically for stage 3 at UC Davis and many other sites across the country, for patients who've had surgery and then treatment after, there's an arm of a trial called the Alchemist trial, which is looking at patients who, after they complete that treatment for earlier stage disease, they get randomized to either go into normal surveillance or to receive crizotinib. And crizotinib's an earlier generation drug. That's not as good, necessarily as good as alectinib, but it was designed before alectinib became the first line standard of care. So there is an option for that trial where patients can potentially get crizotinib in the non-metastatic setting, and then studying to see if there's a survival benefit. Patients live longer, they get the crizotinib.
Yeah.
So before we jump down more potential therapy lines, I want to jump into what multi-modality treatment is, and how you guys determine which patients might qualify for that as opposed to, a single drug therapy or something like that. So what is multi? Again, I'm just going to say that.
Right.
What's multi?
Say it 10 times.
What's multi? Yeah, it's like toy boat.
Right.
I mean, it's basically multiple methods of cancer treatment. So at its core, multiple methods, and then in a sense, multiple people with different areas of expertise also providing input into patient care. So we call it multimodality, multidisciplinary care. So that often involves a group of people who focus in taking care of lung cancer patients within different specialties. So myself in medical oncology, Megan in radiation oncology, lung pulmonologists. We've talked about complications of these drugs, pneumonitis, inflammation of the lungs. They also do a lot of, they can often get to biopsy spots that are very challenging to get. Thoracic radiologists, so the ones that focus in reading the scans. I mean, we're pretty good at reading CT scans, but ones that, they do that for years and years and read 50 scans a day are better. And of course our lung cancer surgeons, who take these things out and often can biopsy things to get us additional diagnostic information. So we fuse that all together, as part of a care team in terms of developing the best way to treat patients. In terms of multimodality, in terms of we think surgery, radiation, systemic therapy, whether that be chemotherapy, immunotherapy, targeted therapy, and that comes into play. I would say everybody gets multimodality therapy in a sense that you're seeing multiple folks with different areas of lung cancer expertise. But in terms of radiation, systemic therapy, and surgery, that it can come into play. I think from tumors that are beyond the small ones that just that get plucked out and don't need additional therapy. Compared to, chemotherapy after surgery for stage 2, chemotherapy and radiation, chemotherapy and surgery, a combination of the 3 for stage 3, and then for stage 4, these all come into play. So I would say, in a sense, everybody, in a sense, gets multidisciplinary care, because even if they don't get, even if they just have surgery, where thankfully it's just a stage 1 that's small that doesn't need additional treatment, we're giving input of, it's probably not worthwhile to give additional treatment because that would potentially do more harm than good. So I would say, we like to say that, everybody gets multimodality therapy.
Well, I would love it if everybody got multimodality team care, but they don't. They don't. Like 20% of the population of lung cancer patients get this kind of care. And that's why we're here, because we want to teach you and everybody online what to go back and ask for. You want multiple sets of eyes working on your cancer treatment. And these people, these doctors, these amazing people see you, and then they go lock themselves up in a room and they talk about you. And they all come to a consensus at some point about what's the right road for your cancer and for your cancer. There's not the same road for everybody. Multiple sets of eyes. That's the key to the future.
Yep.
And we got to get it out there in those other 80% that are not using that kind of care. You've got one doctor who's trying to treat 100 different cancers, can't possibly be up to speed on everything that's happening in your cancer. So, right?
Yeah, it's definitely a challenge, and it's definitely a barrier for a vast majority of patients diagnosed and being treated. And plus, I think there's different people have different ideas of what multidisciplinary care means, and how many people actually need to be in the room in order for it to be a multidisciplinary sort of decision. So it's a big gap and a big challenge. Sally?
Yeah.
What's the difference between that and a tumor board?
Well, I think, talking about that's a great question. I think when we're talking about multimodality care, multiple methods of cancer care, multiple experts, we're essentially talking about that broad set of treatment, but within that, a multidisciplinary tumor board where you have multiple experts reviewing different challenging lung cancer cases to come up with the best path forward. Oftentimes where there's, maybe not one person doesn't have a clear answer, but by discussing among everybody, we chart the best path forward. So I would say a tumor board is part of that multimodality care.
And coming up with multiple things to do for each patient. A little bit of radiation, a little bit of, surgery, a little bit of chemotherapy, whatever.
Targeted therapy.
And then the other thing I would add to that I don't think gets emphasized enough is kind of the psychosocial support as part of multimodality care. So I feel, I think that is absolutely critically important to kind of integrative oncology, dealing, with these challenging situations. And I think, that, we've really tried to, I don't think that in years past has got enough attention, that we're trying to incorporate that more and more at UC Davis.
Right.
Yes, sorry.
As being part of a palliative care team at Packard, when does that get introduced? I mean, that's always been a big problem in the oncology field, that you all do a great job at what you do, but you don't want to bring that particular discipline into it. And for the socio-emotional part, that's a huge factor.
That's a great question. I mean, they even did a study years ago that showed potentially a survival benefit, right, of getting early, palliative care involvement. So, I think, in the reality that could be variable. I think, we try to get it, we try to introduce it particularly for patients with more advanced lung cancer, earlier on. We have that more now in our cancer center, and home-based palliative care is also something I think is absolutely critically important. So, we're doing that where they can do an assessment at home as well and provide recommendations there, from being at somebody's home, which you can often gather more information. So I think, there's that component. There's also, so that's a critical component. There's psychosocial support for kind of mental health care teams as well. That I think is also, important in terms of a broad-based supportive care, oncology. And then, there's kind of the other stuff that, aside from the psychosocial impact, kind of the when somebody's in a lot of pain, how do we manage that? And there's some interventions that, like our pain management anesthesia folks could sometimes give as well, which I think is also important in certain situations.
I just found it really difficult to get to palliative care. I mean, Larry's stage 4, 7 years, and we had to ask about it.
Yeah.
And, we're at Stanford, we're at at PAMF, we're at the top of the line. And it was a big, oh no, you don't need to go there yet kind of thing. And I thought, we have now been involved with palliative care, and I have to say for even the caregiver, that's been a huge support system for all of us in the family.
I think it's a tough discussion for a physician to start with a patient, because it's so related to hospice, and palliative care is not hospice.
Right.
It's a service that helps patients, especially patients that have no families and they're doing this alone, and they need somebody to do some of the intervention and helping along the way, and it's something we have to get through.
And I think there definitely needs to be more education out into the patient community,
right?
But the healthcare professional community as well. The patient community, because I can't tell you how many people have said just the opposite. They wanted me to go see a palliative care specialist, and I was like, get out of this room.
Right.
Right? Like,
exactly.
Because they're not understanding.
I'm not dying. I don't want palliative care. Right,
no,
exactly.
But people don't understand that.
They need to rebrand it, because for some reason it's always confused with hospice.
So we have
and it really needs some rebranding or something.
Exactly.
So they did actually rename our outpatient palliative care recently. It's now the Supportive Oncology Clinic, which I think actually is a nice step.
It's called Supportive Oncology.
Yes.
Well, that's perfect.
I think it's fantastic, because really what they're providing is it's first of all, they do pain management for any patients who need extra assistance with that beyond just seeing their oncologist, and then tie-ins to the social work, referrals to psycho-oncology when needed, help with insomnia and all the many other symptoms, and then I think they're a nice resource for people to be tied in with that clinic, and then eventually, if they at some point are doing worse, then they have a tie-in to home-based palliative care or eventually hospice. And it's more of a continuum, so patients who are not at all terminally ill can still just seek out supportive resources.
Exactly.
Rebecca, describe it, Mike.
My experience, is this on?
Yep.
My experience at Stanford was they offered palliative care in the first year and the second year. By the second year, they explained to me more in detail what it meant and what I would get from that, and also recommended a palliative care doctor who was also an oncologist. And I've been seeing her, and I can't even tell you the night and day difference it has made in my life. I'm not coughing severely anymore. I have so much more energy. I can stay up all day long without sleeping all the time. I mean, all that's from seeing Dr. Machandra. She's awesome. She's just been, and it's not just her that comes out and talks to you. It's a whole team. They come out and talk to you about so many different things. Like even I was having a problem with my son, and they offered to have a specialist writer call me, and she called me that night and went over this wonderful letter that we wrote together for my son and that I was having issues with to resolve those problems. I can't tell you how that much just meant so much to me.
Yeah,
I think it's
very important.
Yeah.
We should have somebody in here to do a whole palliative care living room.
Well, Kavitha Ramchandran, who was a resident with at Stanford, is great.
Done.
So,
Okay,
Great.
get him on the line.
Is that who you were saying?
Yeah.
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 She'd be great to have.
Yeah. Okay.
So, yes. Yeah, Mike. Oh, you have one.
Yeah, I have a question about the cancer board.
Two more.
When I visited my oncologist, they briefly mentioned that my case get reviewed by the board, but would be very beneficiary if we know who are in the board and how much they reviewed, some details that maybe different doctors having some different opinions, and this is the decision. So if by knowing this more, probably we wouldn't have to go to a different hospital for a second opinion or things like that. In Davis, what kind of a procedure or routine that the board meeting does for a patient? Do you review every patient by the board, cancer board? Or when there's a different opinion as far as treatment, how does the board resolve the different opinion? How do you reach out to a decision, whether it's a majority, whether it's the professor, whoever is the chairman, or whoever is the doctor of that patient weighs more, and how does it work? Can you shed some light on that?
I mean, that's a great question. Oh.
Well, I think we can both jump in on this a little bit. We'd have every specialty represented at the tumor board every week, and oftentimes that's more than one. Like for medical oncology, there's frequently 3 or 4 medical oncologists. Usually it is just me from radiation oncology, just because we're a smaller specialty, so I'm the only thoracic radiation oncologist at the hospital. We usually have 2 surgeons, anywhere from 1 to 3 pulmonologists, oftentimes 2 radiologists. So it is a reasonable sized group. I think we try to come to a consensus as a group. If there is disagreement, we'll oftentimes spend a long time on one case. If we don't want to just walk away saying, well, we didn't agree on this. We'll go back and forth and try and figure out why we do have a disagreement. It's not that there's always 100% consensus. There's certainly shades of gray in medicine, and I've absolutely gone back to my patients before and said, well, for example, 3 people, or part of the board thought we should really biopsy this now, and the other part, the other group thought it might be kind of a high-risk biopsy, and we should do a short interval scan of 2 months or so and recheck. And these are oftentimes areas where there's really not a right answer, and it's kind of an intuition thing. I don't know if you want to add.
Yeah, I would say I would echo similar sentiments. I mean, we're usually well represented among all the diverse specialties within taking care of lung cancer patients, and we generally kind of like to come to kind of a Quaker consensus. But when we're not able to do that, we we often say, here are the pros, here are the cons, and it's often, as Megan said, where there's not a right answer, and then it's a further discussion with the patient on, these are the pros, these are the cons. What do you think? There's not a right, there's not a right answer, and have a discussion and a back and forth about that.
They're so forward, though. We actually took a video of the UC Davis tumor board when they were doing a remote tumor board with Truckee and Larry Heifetz. So the docs in Truckee are a smaller hospital. They don't have, the things that the academic centers have. But they have the benefit of dialing in, and some of us were in Truckee and the others were in Davis, and we watched the whole. We'll play it for you one night.
Yeah, and I think it's
pretty
a good
cool
point, because I think it's really important to note that not all hospitals around the country, or God knows the world, are the UC Davises of the world, where they have the benefit of being able to do this. So what sort of role might some sort of telehealth be able to play in helping some of these smaller, either hospitals or even just private practice, physicians working in,
when that community hospital gets that tough case where they really
to be able to make these decisions,
it's not really okay. I did genomic profiling. They've got an EGFR marker. We're going to stick them on Tagrisso. Life is good. But when they've got the tough case and they need those other eyes, you can do that. I mean, and a lot of that's going on today, and we do that with our community centers of excellence, and they want to participate in things like this because they're never going to have the resources that a huge academic center has, but they can deliver academic care. They can, if they want to learn.
Yeah, I want to jump into some examples of some exciting, while we've got Dr. Daly and Dr. Riess here, that are happening, and we can focus at the moment, or for the moment, on how medical oncology and radiation oncology come together in this multimodality type of treatment options. What's happening that's exciting now, currently available, and we're using on patients, and what's coming down the pipeline? Because I just want to be mindful of time, and I want to get to the meat.
Yep.
So I don't know who wants to start or take over.
So I would say, in terms of multimodality treatment with radiation and radiation oncology and medical oncology, probably the most exciting thing going on there that's been widely adopted around lung cancer is, chemoradiation and then immunotherapy with durvalumab after chemoradiation for stage 3 locally advanced non-small cell lung cancer. So dramatic difference in time, in survival and what we call progression-free survival, which is the time it takes for the cancer to come back and increase in size, but also overall survival. And so dramatic difference. And so that's the new, essentially, for many patients with stage 3 lung cancer, the new standard of care. And now there's multiple clinical trials, looking, additional studies looking at how you sequence the immunotherapy, when it involves surgery and so forth. So that's probably the most exciting thing standard of care-wise. And I don't know, Megan, if you have any other thoughts. And you also have, Megan has a number of clinical trials with immunotherapy and radiation, which I think are really exciting too.
Yeah, I want to hear more about that.
Yeah, well, I think in general, the emerging role of radiation in metastatic lung cancer is very, very exciting to me, and that's in a couple of different ways, some of which I would say are not quite standard yet, but are quickly becoming close to standard. So before I jump into the radiation immunotherapy, which I definitely want to talk about, there were a couple of trials that were published just over a year ago looking at the idea of, patients who have stage 4 lung cancer but have not too many metastases, just a handful, 3 or fewer. What happens if you radiate them after you do your frontline chemotherapy? And 2 separate, admittedly fairly small trials done in close succession actually showed what appears to be a survival benefit to doing that. So that's now being tested in big randomized phase 3 trials, but we have a lot of hints from smaller trials that actually radiation can be very effective in that setting. And actually it's a pretty marked survival benefit in some of these studies. So I think that on its own is very, very exciting. The radiation is almost acting like a drug there. You're debulking cancer, you're getting rid of tumor deposits.
Why only such a small amount of?
It's not a hard and fast number. It's basically what you can treat safely at one time. We don't know what the right number is. And that's where we need more studies as well as some just good clinical judgment to figure out what the right number is. That's what a lot of the trials looked at.
Do you see it following kind of the same route, and then Rick will go to you, as like some of the early studies when they were talking about like CyberKnife and all that stuff where it
may. I have a feeling that 3 is probably conservative, but there is a point where maybe you want to find a more effective drug first.
Sure.
Why stage 3?
Oh, stage 3 for, stage 3 because in terms of the chemoradiation and then immunotherapy afterwards, that's because typically before that, for stage 3, it was typically chemotherapy and radiation alone. Although in certain cases, because stage 3 every case is unique, but stage 3, it's really unique because there's multiple things that could make it a stage 3. So sometimes, we do surgery and other treatments, but, the standard for most patients is chemoradiation. So that's where then they said, well, hey, let's add immunotherapy. Of course, now we're also doing it with, surgery and also, before surgery because you have all these antigens there from the lung cancer and trying to stimulate the immune response. So now, as you could imagine, these immunotherapy drugs are studied in multiple settings across early stage to stage 3 to metastatic setting with every combination you could imagine. And so with surgery, there's some promising data. There's some great data with, PD-1, nivolumab, before surgery. And, another trial called the NeoStar trial that's looking at 2 different immune checkpoint inhibitors. And there's, at UC Davis, as there are many trials looking at, bringing the chemotherapy not after a stage, not after, but before with immunotherapy, while you have all those antigens from the tumor still there, and then taking it out with surgery. So, a lot of exciting advances trying to really take all the great benefit we found in the metastatic setting and trying to increase cures in the early
and hit it
stage
hard.
3 setting. Exactly.
Just hit it hard.
Exactly.
Yeah.
Rick?
So, talking about CyberKnife radiation, they talk about how many spots you can hit, but is it volume based or is it spot based? The reason I ask, I have 14 metastases that they're tracking, so that means there's probably another 10,000 that they can't see yet, but whatever. They treated 2 of them back in 2017, and they have not resurfaced. They still scan because it's like dead tissue or whatever, but they haven't come back. No growth, no activity. And I just had 3 more done last month, so that's 5. And when we were first talking, they were talking maybe 12 was a limit, and then they were talking maybe 20 is a limit because that number changes. But I would think it'd be more volume-based than quantity-based. Is that true?
It's a combination of the total volume, the distribution in the brain, where they're located, are they close to anything sensitive, how big is each one?
But that's a targeting issue. I mean, as far as overall radiation that you can tolerate, is it based on cubic centimeters or
It isn't actually a targeting issue, so actually it is a safety issue. Full disclosure, I actually don't do brain radiosurgery. We have a gamma knife at UC Davis, so we have 1 brain tumor specialist who does it. So I'm not actually making these decisions day by day. But broadly speaking, it's yes, 10 small spots is much safer than 10 really big spots, because if you get to a point where you're going to you hit a tumor with radiation, you're still going to have fall off around it, and it's a matter of kind of maintaining a safe dose kind of overall to the brain, to particularly critical parts of the brain. For example, if it's a bunch of these are in the brainstem, that gets a little bit trickier. If they're right next to your optic chiasm, that gets a little bit trickier. So there's some nuances, but the folks who do this are getting more and more comfortable with larger numbers, as you've seen. I think there are some centers treating up to 25 or 30 in select cases. So they're when I first started my residency, 3 or 4 was the cutoff. So we've come a long way since that.
Yeah, and I've been fortunate. Mine are small. Everything they've gone after was right around 5 to 7 millimeters, relatively small. The plan is to continue on meds. Hopefully that at least slows progression down, and from time to time, hit what you have to hit.
Yeah.
It's kind of the plan. So we're doing
reasonable.
both targeted meds and radiation.
Yep.
So Rick could be on the tumor board. Yes. We could do a remote call.
Yep.
Go ahead, Megan. Yeah.
Well, and I think coming back to the idea of you integrating radiation in the stage 4 setting, there's a lot of really intriguing preliminary data to suggest radiation may help immunotherapy work better. It may almost act like a drug. Because with immunotherapy, what you need is for your body's immune system to recognize the tumor. So you go in and you radiate a tumor, and you have all these dead and dying tumor cells at the area where you hit the tumor. So there's a lot of animal work and some sort of intriguing preliminary data to suggest, at least for some people, radiation may really help that immunotherapy work better. It may kind of boost it. So there's a lot of ongoing trials in that space, including several that we have at UC Davis. For example, looking at people who've gotten an immune checkpoint inhibitor, something like Pembro or Nivo, and they've responded for a while, and then they start to progress. Can we kind of get them to start responding again by radiating one of their tumors? And there's a lot of centers around the country doing similar studies, but I think this is a really exciting area too, because we're really using radiation more like a drug in those cases.
And we're doing more and more of, like you had mentioned, radiating a site of some site of what we call oligo. How you define oligo is, kind of in the eye of the beholder, but a few or one growing area, and then, continuing a drug, continuing the same targeted therapy and so forth, and can often get additional mileage by doing that. So, and we have been more aggressive, as Megan was saying, in terms of, patients who've done well on treatment and something pops up after, a long time, focusing radiation on that and kind of keeping that same therapy going. I mean, in terms of multimodality therapy, Megan gets sick of me paging probably literally 3 times a day. Should we radiate this? Should we radiate that? What do you think? But we're always thinking of how we can maximize, how can we get the most mileage out of every treatment we give so how can we keep it going? And oftentimes we can keep it going for some time longer.
And a lot of that is keeping progression from happening, right?
Well, it goes back down to that chronic management you were talking about.
Right.
Is the thought behind it, and then Kat, I see you, and then I see you too, Rick, and I see you too, Larry. The thought behind oligometastatic disease and treating it as such is that the systemic therapy is generally working in 80% of the cancer. It's just this couple little spots that are resistant to the drug.
Especially with oligoprogression, you may have had one tumor cell that became resistant and forms this little resistant clone. So if you get to it fast enough, and maybe the drug will continue to keep everything else in check. It does not always work, but sometimes it does.
Sure.
So it's a good option to try.
Got it. Kat.
Can you speak to a little bit about radiation in general and how it works? Because it's something my mom really wanted to look into, and what we understood is that you really can't radiate the same spot or spots more than one time, and that you want to leave it more in the back pocket of the future when it's maybe you have more symptoms, it's causing more pain or problems. So it's something that has kind of come up in different appointments we've had with different oncologists, but it's still not really clear to me how that all works. If you understand.
So radiation very broadly means we're aiming X-rays in a very focused fashion at a particular tumor. And we use pretty fancy targeting nowadays to do that. So we base it on a CT scan. We can sculpt the radiation beams. So we're trying to hit as few normal tissues around the tumor as possible. However, it's still photons. It still has to pass through some portion of your body to get to the tumor. So, and the way radiation kills cancer cells is it damages DNA. It causes breaks in the DNA. Cancer cells are not very good at repairing those breaks in their DNA, so the cells tend to die. The normal tissues in our body are much better at repairing those breaks in their DNA, so they tend to heal. But there can be damage to the normal tissues, and different types of tissue in our bodies can be better or worse at repairing DNA damage, and they can be more or less sensitive overall to radiation. So It's not that we can never irradiate the same part of the body twice. It depends on what dose was given. It depends on what that body part is. If it's a femur, it's a lot easier to irradiate it than if it's right next to your optic nerve or right next to your spinal cord. Those are cases where we have to be much more careful. We definitely can re-irradiate in various situations, but we have to. It's a lot higher risk and it's a lot more careful. So we definitely don't radiate something unless there's a good reason to radiate it, because we don't want to suddenly need that radiation again a year later. But at the same time, we shouldn't be afraid of treating something if it's needed. And if we do need to retreat it again in the future, there are ways. Our technology is pretty good, and there are ways of working around it.
Thank you.
I don't know who was another point.
In terms of metastatic progression and radiation, is there any difference in feeling about primary source and metastasis source?
When we're thinking about using radiation for somebody who has metastatic disease, we'd obviously want to try and control the primary as well. It doesn't really make sense for us to radiate the metastases for control while not dealing with the primary. Now, we sometimes will radiate a metastasis for other reasons, for symptom control or to prevent a bone fracture or to prevent tumor from pushing on the spinal cord. But if we're looking at something and saying, well, there's limited sites of metastatic disease, let's use radiation as one of our tools to try and control it, we would definitely want to try and control the primary tumor too. And those studies that I'd mentioned, they definitely they controlled the primary tumor as well.
And is what you're saying really what personalized medicine really is? And it's really looking at each patient, and what's going on with them physically, their age, other factors, and really putting together a plan, very, very, very singular for them.
Absolutely.
Yeah.
Yeah.
Rick, I'm coming around.
So is radiating the lung common, not common?
It's
very challenging. It was never done on me. As it worked out, the primary site doesn't show up on a PET anymore because of the ALK inhibitors, and crizotinib, which is the first one I was on, pretty much knocked it down. Of course, didn't do much for the brain because it doesn't get there. And then I did X396, and I continued to have slight progression in the brain, but the quality of life was so good, it was worth it. It's like, well, perfect quality of life, progression is really, really slow, just keep going. Couple spots ended up having the CyberKnife in 17, and eventually I switched over to alectinib, which is a great drug for the vast majority of alkies. Terrible drug for me, side effects were horrible. And eventually ended up on brigatinib, which I'm tolerating really, really well. But the brain is the only real challenge. And none of these drugs are perfect for getting to the brain. They get there, but kind of so-so. And whole brain radiation is, as far as I'm concerned, kind of off the table. That's a way down in 2055 or something. We'll look at that. But CyberKnife seems to be the solution, at least in the reasonable future, to go at spots as they pop up. And that seems to be the strategy we're using until, of course, they come up with a new wonder drug, and then that'll go everywhere, and that'll be great.
It's part of chronically managing your cancer.
Absolutely. And, we've been managing it for almost 5.5 years now, and my quality of life is really good. So kind of if it ain't broke, don't fix it.
Jennifer, Marie, Amy. I hope I didn't miss anybody. Yes.
Okay, I'll be quick. I just had my PET done, and as I mentioned earlier, everything is great. And my remaining cancer is my primary cancer, which is in my lung. And I did ask the doctor, I says, well, why can't you just radiate it? If that's all that's left, why can't you just go in and poof, make it gone? And he tried to explain it to me as best he could in layman's terms, if you will, kind of like when you hit something with radiation, it kind of has a plop effect where it really kind of doesn't just zap it and it's gone. It kind of has a residual, and you never know, and I'm asking you for clarification on this, but you never really know what it's going to turn into. So even though you might be zapping it and it's breaking up and there might release pieces into your body or something, it could actually be a different type, or it could turn into a different mutation. I mean, am I explaining that right? The way we talk.
People ask this question a lot, so I'm really curious to see what.
Yeah.
There's really not evidence that radiation is causing bad mutations in tumors. I mean, what we're doing with radiation is killing the tumor in
Right,
a
but
very.
The part that breaks off of it doesn't necessarily break off in the same form that it was zapped as, I guess is my question. Am I saying the right?
No, I'm just not sure I totally agree with the.
Yeah.
And I'm not sure I understand.
You're explaining it right.
Yeah, I think you're explaining. I definitely hear people come in and say they've been told that too. Really, what we're doing with radiation is we are taking X-rays, we are aiming them at the tumor. It is damaging the tumor cell's DNA, and if we give it a high enough dose, it is hopefully killing all of the tumor cells in that particular sphere. Now, that doesn't prevent other tumors necessarily from not coming back someplace else if there's any other cells floating around, or if we don't manage to kill 100% of the cells. But they're not really breaking off and
There's
float.
no plop effect.
Yeah, not really.
Flopping all over your body.
No, it's really kind of dead.
Right.
Hopefully, live tumor dying in this, and then eventually, I mean, you have some. There's some shedding of dead, little bits of DNA of the dead tumor cells. But now, in a very long-term sense, and we're not talking months or even years. Radiation, as I'm sure everyone knows, radiation can cause cancer, but that's usually an effect decades later. So when you're talking about a radiation-induced cancer, that's typically something you'd see 20, 30 years later, and it's usually a reasonable risk to take. It's a pretty low risk in the context of being able to use an effective treatment.
And the other medication is working as well.
Mm-hmm. Yes.
That you're taking.
Yeah.
But this is my question, and patients do ask it a lot, and I'm like, ask your doctor. But if your body's responding to whatever your systemic treatment is, and you've got that one lesion left, why not radiate it?
These are the things we discussed in our multi-modality
Exactly.
tumor board. So
Right.
these are the kind of cases, hey, the patient's been on treatment for a year,
Knock it
everything's
out.
great.
Yeah.
There's this one little spot.
Yeah.
Should we go after it?
Yeah.
This is what I page Megan 3 times a day about.
Exactly.
So,
Yeah. There you go.
There's not a right answer.
So,
Yeah.
I think it depends on how long, because we worry that, more likely than not, there are other seeds that are out there that eventually, unfortunately, will sprout. And that's the reason for the systemic treatment. But if somebody has, good control for some period of time, and what that amount of time is, I think is not clearly defined. But if there's a spot that could be radiated, that's an area, and patients have shown themselves and shown that the treatment that they're on has provided long-term disease control, it's just so tempting to go after. So that's something that we discussed. That's something that Megan was talking about with those clinical trials. It looked like there's a signal, of benefit in certain defined situations. Now, how broadly that is, I think we don't know yet.
I mean, I say this because we have a patient she was a young patient. She did chemotherapy, several different types, right? She had I can't remember which type of targeted radiation therapy in sort of a whack-a-mole capacity, right? And she was a stage 4 patient, and she's been no evidence of disease for like 4 years now, right? So it's sort of that's some studying that needs further Yeah. Okay, Marie, sorry.
Actually, this is a great conversation, so thank you for being here. I think I have something very similar. I had a question about talking with my general oncologist. At stage 4, I had a large, of course I have it's metastases to my adrenal gland and my lymph nodes, but there's this big tumor in my lung. Why not just zap it? And she's like, well, the medication will reduce it. And I'm like, well, why not reduce it and then do the medication? Again, she explained it in layman's terms, but it just didn't resonate, so I couldn't really understand, if it's in the adrenal gland and some lymph nodes. I guess I don't know what happens if you radiate a lymph node what happens, and would it be beneficial to reduce the tumor size before you do the chemotherapy? But the other question I had, that was one, based on what a couple people said here. And then the other one is, I didn't know you could re-radiate an area. So with the femur, it seems to be that for lung cancer patients, one of the most common things to happen is the bone mets in the femur. And I've already had radiation, and there's a lot of sclerosis. So how can you see if there is an active tumor within the sclerosis area that they didn't quite catch everything?
It would probably pop up in a PET scan.
It will pop up in a PET scan?
You would be able to see it on a PET scan, probably not a CT.
And can they radiate the area that has a lot of sclerosis around it? And does everybody know this?
I mean,
like, community doctors, community oncologists versus academics.
There was an RTOG, which is what the NRG used to be. It's a big cooperative group, and quite a while ago at this point, probably close to 10 years ago, they did a trial looking at repeat radiation for bone mets. And I mean, even at the time, we all thought it was a fairly simple trial, but it is generally safe. You sometimes use a little bit of a different dose and schedule, but where it becomes very tricky is if you're treating in the spine. So somebody's already had full dose radiation over their spine, and they have a new spine met that looks threatening. That can be pretty complicated because you're right next to the spinal cord. You have to be super careful. With the femur, it's actually pretty straightforward.
And that would help reduce pain.
Yeah, if something came back in the same spot in the femur, so, I mean, the femur, one of the main reasons we tend to jump on that quickly is it can predispose people to fractures because it's just a bone that we use so much, and so it's weight-bearing. So unlike a lot of bones in the body, even if a femur fractures, a femur met is totally asymptomatic, I usually treat it to try and prevent it from causing symptoms, whereas if somebody has a totally asymptomatic small met in their scapula, a lot of times we would say, just get systemic therapy and watch it.
Yeah, I had the radiation, and it was such a breeze. And he said, "Oh, and when you're done with this, you will be able to walk. You won't need your crutches anymore." And I told him later, I'm like, "Yeah, set the bar low." The pain never really went away, and so they found a new lesion. So I guess for a patient, maybe my new oncologist, or maybe I misunderstood my radonc doctor. It could be that I just misunderstood. And then my first question, why not just reduce a large tumor and then concurrently do the for stage 4?
I mean, so based on our current understanding, I don't want to make radiation sound like it is the cure for everything, and I'm not trying to give that impression. We wouldn't usually say, well, we're going to try and radiate the biggest tumor and we're not going to radiate the other tumors. Usually when we are doing this approach of trying to radiate limited metastases, we only do it in a setting where we can actually radiate all of them. So if we can't do that, usually we would start with a drug therapy and go from there. And it doesn't mean we wouldn't consider radiating something in the future if it's the only site left or the only site growing, but we wouldn't say, well, this is the biggest tumor, we're going to radiate this, but we're going to leave the other spots growing. Right now, none of the studies we have suggest that's beneficial.
I think one of the analogies was it doesn't really matter because it's like the tumor, once it's metastases, it's like all in a stream, and the stream is circulating throughout your system. And I'm like, but I'm trying to envision it going, well, something that's larger is going to be producing more cancer cells than something that has been reduced in size. And the answer was, nah, it doesn't really kind of work like that.
Well, I think our biggest, our concern about radiating is depending on the situation, in a sense that if there's multiple spots out there, you wouldn't necessarily go after the largest spot with the other spots out there. Looking at it as almost like, a weed you pull up. You pull up the weed, but there's still seeds and things still there. Unless somebody was having symptoms, then, oftentimes to help relieve those symptoms is the primary goal. we initiate radiation. Now, I think getting to your point, well, why not just radiate everything? And, you know, what we worry in that situation, without establishing some type of control, like the situation we talked about before, where somebody's on a targeted treatment for a year or two, and there's just a few, you know, spots out there. You know, you worry, you spend all that time finishing radiation, and then you get another scan, and lo and behold, there's a bunch of other spots, and you're playing catch up. So, you know, in some of those situations, that's our main concern. We feel in some situations may not be as helpful, and then in other situations, like we outlined before, could be potentially helpful. And like I said, a lot of times there's a gray area, and that's where we have our multimodality, disciplinary discussions.
And there are potential side effects to radiation, and those risks increase the larger the number of spots you're treating. So not that there's a hard and fast limit on exactly the number of spots you can safely treat, but eventually you're just going to have too many side effects.
What's the next big thing happening?
Well, I think you got at something in the, you know, before you mentioned, you know, if you look at kind of the evolution of how we take care of cancer, kind of it's having drugs that act together that are synergistic, that, you know, have a multiplicative effect, where the toxicity is manageable and not overlapping, and so how they developed, you know, how they cured testicular cancer, you know, how they cured lymphoma, even if it's metastatic widely, is taking that principle and then bringing it up front to prevent any resistance from the cat getting out of the bag. So I think the future of lung cancer care, at least for metastatic cancer, is to find these targeted therapy drugs, these immunotherapy drugs, and, you know, how best to combine them that overcomes this resistance, and not to do it after the fact, but to bring it up front. Yep. And then from there, potentially monitoring through plasma, although the sensitivity may not be there yet for low bulk disease and so forth, for resistance to develop, and if you detect something, potentially add another drug.
Right.
You know, not unlike in a sense how they came up with, you know, combination therapy for HIV or for other cancers like testicular cancer and so forth.
Yeah. Hit it hard.
Yeah.
Don't wait. Yeah.
So we're at the bottom of the...
We're out of time is what we are.
And I know there's a question online, so...
Well, it's not necessarily online. It's mine, but I don't know that we have time for it. It's very sciencey, and I don't know that we've really delved into it. But often people ask me to explain the abscopal effect and how that is, you know, being leveraged kind of in the lung cancer space. So can you kind of give a quick and dirty explanation of what the abscopal effect is, how people are trying to use it in lung cancer treatment?
So the true abscopal effect is the idea that you radiate one site, one tumor in the body, and a tumor elsewhere in the body that was not radiated also shrinks. And it's related to generating an anti-tumor immune response. And that's a true abscopal effect. So in a true abscopal effect, there's no drugs involved. It's just radiate one site, other sites respond. And it has actually been described very well in the literature, but it's very rare. But we're now trying to do, as we were talking about earlier, combine radiation and these immunotherapy drugs together, and seeing more robust responses elsewhere in the body when you add radiation is kind of a soft form of abscopal response.
Cool.
That's interesting.
Yeah, it is.
That's very, if you figure that out.
It is very sciencey and very sci-fi as well.
To make that happen over and over again, that would be very cool.
I have to go through some housekeeping, but before we do that, I want to thank Dr. Daly and Dr. Riess for coming out and speaking with us.
Thanks for having us.
Great conversation. Thank you for all of your questions. It took us a little bit off of but we always know that it's about what you guys are looking for and what you want to hear. So thank you for asking. Up next, number one, if you have not already done so, and you might want to consider it, please join our lung cancer registry. I think most people in the room have joined it. Some of you are new to the room. We can give you more information about it, but you can find it at lungcancerregistry.org. It's a really great way to be able to give back, donate some of your information, if you will, de-identified, that we can then go back and share with the research community so that they can maybe find some commonalities or some things that they need to know when they're designing what their what next is. So please consider joining the registry.
Those are called patient-reported outcomes. You know, and those are outcomes directly from the patient into the registry and not passing through somebody doing data entry at the facility. So they're really actually more accurate. But designing good clinical trials requires data to give you the information before you actually complete the design of the trial that gives us the information that the trial has a much better chance of succeeding because we've already seen it, you know, pulled together in a registry. So it's really important for you all to be part of this and to get others to be part of this too. This is huge.
Yeah, and we have more information. We've got flyers out in front. If anybody online is interested, you can reach out and we'll get you to the right person within the organization to give you more information. Next living room, March 17th.
St. Patrick's Day.
And the anniversary of your surgery.
Yeah.
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 Yeah, so
That was a good day.
Big day here. We're having a conversation around stigma, which I'm really, really excited about. Because I think when we think about stigma as a general rule, we think of somebody shaking or pointing a finger or thinking a patient is deserving because maybe they had a smoking history, right? But what I don't think we think about is what that trickle-down effect looks like and how that stigma has affected so many other things sort of on the, so many other spokes on the wheel. So we've got Jamie Stutz, who is he's a PhD, he's now at the University of Colorado, but he was in Kentucky for a long time at University of Kentucky. He's done a lot of work in the area of stigma. So he's going to be coming, as well as Jim Pantelis, and some of you may know Jim. He's a big advocate and very big in the stigma arena as well. And then Stephen Huff, who I think most of you don't know. He's a young stage 4 patient out of Nashville, who just had a baby about less than a month ago, I think.
His wife had the baby, right?
Well, his wife had the baby. Yes, his wife just had their baby about a month ago. But he's really digging his heels into this whole stigma space. So I think next month is going to be a really exciting, sort of different, not really a clinically, driven or treatment-driven living room, but a very important one nonetheless. So please come back and tune in for that. March 14th. Run Amok in Gainesville, Florida, with
there you go.
The one and only Karen Gorenberg.
Yeah.
Karen is a long-time stage 4 lung cancer survivor, and she has an event for us every year in Gainesville, Florida, and it's a 5K, and she calls it Run Amok with the Duck.
She's about this tall. She's a stage 4 lung cancer survivor, and Gainesville is a fairly small city, and no one says no to her.
It's true.
She goes around to all of the people that are in business and doing this, the mayor, the governor, everybody, and everybody's there.
Karen and her family have been involved since the very beginning. So if you know anybody in the North Florida area, or if you are in North Florida watching, please go check out the link online to the Gainesville Run. March 15th, Jog for Jill in Berkeley. Here, California here. So anybody in the room who wants to go spend a day out there, or anybody again online who might be watching and wants to head out to Berkeley for the Jog for Jill on March 15th, please do so. And then March 28th, we'll be up in Sacramento. So,
well, that's crazy.
Yeah. So anybody, again, who might be watching from the Sacramento area, I have a feeling, I know there are a lot of patients in the room are patients of one or the other of these two, and I'm certain a lot of you watching are. So please come out and join us March 28th in Sacramento. A huge, huge thank you again to patients, caregivers, and to our panel. A big round of applause for all of you. And then I will close out by thanking our supporters, which is a very long list. But without their support, we wouldn't be able to bring this to you 18 times a year. Amgen, AstraZeneca, Bayer, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Foundation Medicine, Genentech, Lilly, Merck, Novartis, Oncocyte, Takeda, and Tesaro. Thank you all so much for supporting this very valuable and important meeting for all the patients out there. So
And
thank
when
you
will
all.
this be on TV for you to tell your families?
So I
know your mom wants to see it.
You can go back and watch it on. You can go back and watch it on Facebook on the GoTo Foundation site right now.
Right.
It usually shows up on YouTube, the full 2-hour version, within 24 hours, and then it's about 3 weeks before the edited version will show up on our video library and our website. But we'll send that to you guys once.
But if you can't sleep at like 3 or 4 in the morning, Channel 26.
Channel 26, Peninsula Television.
Right.
I didn't thank the food or the.
Thank you to the Office
Penn
Bar and
TV,
Grill.
who brings their entire TV studio down here once a month and shoots this for us. A big thank you to Penn TV. A big thank you also to the Office Bar and Grill for donating the food every month. This time it was sliders. So
yeah,
thank you to the Office Bar and Grill.
Yeah.
And if you didn't get any, please come get some. And Ron's not here, or else I would thank him for his coffee crunch cake. And he and Sally usually have a. Karen did? Where's Karen? I don't know. No, Ron brought it.
Cake.
Oh, cookies, and there's all kinds of stuff up here. So thank you to Karen and Ron, and I think Andrea, who brought caramel apples. So come and get it. Thanks, everybody.
And you guys load up so you can eat on the way home.
Yeah.
Thanks so much. Okay.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.